Face it, but that was the only choice I had. Every painful moment in our lives teaches us one thing that we can always count on: hope. With the precision of diagnosis, treatment, and follow-up, I was always a cancer. I thought it was all over. Days numbered and dreams given up. But I had to face it. But that was the only choice I had. Every painful moment in our lives teaches us one thing that we can always count on:
Good afternoon, everybody. Hello, I am Dr. Anil Kamath, and we follow. This pandemic should make us relook at the way we should be leading our life in future. So we'll be using this opportunity to educate the general public about cancer. So this discussion will be in the form of a discussion where I am a surgical oncologist and Dr. Vishwanath is a medical oncologist. And both of us have been in this field for almost now about 13 to 15 years now. And we will have a discussion in which we hope to educate the general public about what cancer is. So let us start. So today's agenda would be problems. There is a lot of pain. So let us go to the absolute basic. What is cancer? So I would like to say a few words, and then Dr. Vishwanath will add to whatever I have this thing. See, just as there are millions and billions of people living on this earth, even our body is made of many cells. There are trillions of cells in the body. And just like we have a lifestyle, we are born, we go through our lives, and finally we die. Each cell also has got a cycle, a life cycle. So a cell is born, it duplicates, and finally it dies. So what happens in cancer is basically a disruption of this lifestyle. A cell is programmed such that it originates in a particular way, it replicates in a particular way, and finally it is destroyed in a particular way. Now, if a cell does not, the destruction is called apoptosis. But suppose a cell does not die when it is supposed to, anything which lives beyond its utility causes harm. And this is where cancer sets in. When the cell doesn't follow its normal life cycle and doesn't die when it basically becomes rogue. So there is more than what the body can sustain or what that area can sustain, and this leads to excessive growth of this particular cells. And when that local area is not able to sustain these cells, they tend to spill over into the blood and go over to many other areas. So this is what cancer is. So Dr. Vishwanath, anything more you would like to talk to them?
So thank you, Dr. Kamath, and we welcome you all for this interactive session. And so just to add to what Dr. Kamath said, there are various features of a cancer cell. How is it different from a normal cell? It is derived from a single source, so there is something called clonality. And not only that, it has the ability to spread, like Dr. Anil Kamath mentioned, that is called as metastasis or secondaries. And the normal characteristics of a cell are lost, and this is called as anaplasia. So these are the general characteristics of a cancer cell, apart from what is called as loss of control or autonomy. So these features make a cancer cell different from a normal cell.
Okay, now the next question will change. We both discussed that cancer is caused basically due to disruption of the cell's behavior. The next question which I think would come in anyone's mind is what causes this disruption? So if I have to say, it is like a question, why is there a terrorism? Now the terrorism issue is there because there is something internal. There is some discontentment internally, and there is some external factors which breed on this discontentment internally. So basically there has to be both internal factors and there have to be external factors. Similarly, when what causes a cell to go rogue or go out of its this thing is some of things are present within the cell and some of it are present outside the cells. I think Dr. Vishwanath will elaborate on what the internal factors and what the external factors are.
Yeah, so there are various risk factors for cancer. So like Dr. Kamath mentioned, internal factors and external factors, I would put it across as non-modifiable risk factors or something which cannot be modified. So number one is age. We all know that as age advances, there is abnormality in the chromosomes and shortening and some of various structures of the chromosome, which is called telomerases. And because of this, cancer can happen, and this is something which we cannot modify. We cannot modify our age. And similarly, there are certain cancers which can be common in females and certain cancers which can be common in males. So there's a gender preference to it. And hereditary, just because of the familial presence of a certain cancer, there could be prevalence of cancer in that particular family, and there are certain cancers which can run in family. For example, breast and ovarian cancer, there is a 10% chance that any breast or ovarian cancer can be associated because of hereditary association. And now there are certain modifiable risk factors. So quite a few conditions can be modified. For example, habits like tobacco and alcohol. These are important risk factors for cancer. And our general lifestyle nowadays, because of urbanization and the change in the lifestyle and low intake of fruits and vegetables and high intake of calories and these junk foods, all these things can lead to mutations or genetic abnormalities in a normal cell, which can lead to what is called as mutations, and this can lead to cancer. And apart from this, there are certain infections. We think there's that general thing that infections do not cause cancer, but there are certain infections like bacteria, like there's something called H. pylori which can cause stomach cancer, and there are some viruses which can cause liver cancer, so on and so forth. So these are the general risk factors for cancer.
Yes. Now, the one thing that at least my relatives or people known to me always ask me is that why has the incidence of cancer gone up so much? So they always tell me that cancer was not heard of that much in maybe even I would say about 30-40 years back. So I always tell them that the single reason why cancer has gone up is because people are living longer. Most of the cancers are related to age. So elderly person, more chances of him getting cancer. And of course the other factors like lifestyle and this thing. And the other thing that we have to consider is that there is better detection of cancer. Now, if something is wrong, there are ways in which we can detect it and know what is wrong with the person. Probably earlier this would not have happened. The person would have just died and nobody would have known what has happened. So any more thoughts about why the incidence of cancer is increasing now? Is it a true increase or?
So I think you have mentioned most of the points. But apart from that, I would also again stress on the fact that this urbanization and this change in the lifestyle, which has significantly contributed to this. And nowadays we are seeing that there are certain aspects, for example, women are getting married late in life, over the age of 30. That again increases the risk of breast cancer. And not only that, several women want to be unmarried. So this also contributes to breast and ovarian cancer, because nulliparity also contributes to breast and ovarian cancer. And of course, these are the main things which I can think of at this point in time, apart from the pollution and so much of air pollution and the way our environment has changed, and the genetically modified way of our vegetables and fruits, all these things may be contributing.
All this would have contributed to this thing. So there is something like a true increase because of all this lifestyle this thing, and a apparent increase because of better detection. We have now much better diagnostic facilities. Cancers at very early stage can be detected. Probably this was not true even a few years back, I would say. And cancer, then of course, what are the types of cancers? Now we use the general term tumors. What I would like to stress is that all tumors are not cancers. When you are telling a tumor, it's basically a overgrowth or a lump. Tumors can be of two types. One benign, which is harmless. Once these are removed, very unlikely that they will cause any harm. These are not something to be bothered about. So, and on the other side, we have malignant tumors. Malignant tumors have the potential to grow, multiply, and spread to other areas. The spread is the crucial word here. Anything which goes away from its area of origin would be a feature of cancer. So many times unnecessary this one headache is caused because people mistake benign tumors to cancer. Most benign tumors, we generally don't use the term cancer for benign tumors. It's always kept reserved for malignant tumors. So maybe Dr. Vishwanath can tell us about the cancers in the various parts of the body and which ones we commonly encounter.
Yeah. So like Dr. Kamath mentioned, the incidence of cancer is increasing globally, and even in our country, almost a population of 1.2 billion, this almost 1 million cases are diagnosed every year, and the recent data shows that around 10 lakh people are succumbing to cancer in India itself, and Bangalore is no exception to that. And even in our Bangalore city, the incidence of cancer is increasing significantly. When it comes to males, it is mainly the lung cancer and the oral cavity, the head and neck malignancies, which actually predominate. And when it comes to females, it is mainly the breast cancer and the cervical cancer. So these are the main cancers which are common.
Yes.
Anything else you would like to add, Dr. Kamath?
In India, if I have to pinpoint at a single factor, it is tobacco. Exactly. So tobacco is, in India, people consume tobacco in many different ways. Apart from smoking, the tobacco eating habit through betel nut and all, that causes oral cancer. India, in fact, is the oral cancer capital of the world, I would say. The number of cancers, oral cancers which you find in India, it might be equal to what the rest of the world contributes. Smoking also directly contributes to lung cancer. So tobacco, both smoking and non-smoking, it would contribute to almost 1/3 of India's cases. When we come to females, it is breast and cervix. Bangalore, unfortunately, has the dubious distinction of having a disproportionately high number of breast cancer cases.
So, Dr. Kamath, since your training has been from the premier Tata Memorial Center in Mumbai, I'm sure, and you also told me that your thesis was in head and neck malignancy. So, any pattern you've seen during your 3 years of training there? Which part of country, which part of India was the proper training area for head and neck malignancies?
I would tell if we go northwards, especially the UP Bihar belt, there is a huge amount of tobacco chewing. Some children start chewing tobacco from the age of 7 or 8. Sometimes their grandmothers give them betel nut to chew or tobacco to chew. And the incidence of oral cancer in these places is astounding. It's a very high incidence as compared to anywhere else in the world. And any major cancer center you go, be it Tata Memorial or Kidwai or this thing, the commonest cancer which you can see is oral cancer. This would be at least twice as many as the other cancers. So, but having come from that one, now coming to a corporate setup, like India, there are two different worlds. Oral cancer, which is so common in government hospitals, we don't see that many oral cancers when you come to a private hospital, probably because we are seeing a more affluent society. Typically, we see more of breast cancer here or gynec cancers here, which are more related to obesity or other this thing. So I can tell there are two different types of Indias, even in terms of cancers. Of course, it's true for almost everything, including cancer. The type of cancers which you see in rural areas, which you see in government hospitals, is very different from the type of cancers you see in urban this areas and in corporate hospitals.
Okay. So, Dr. Kamath, now since we have spoken about the general incidence and the burden of cancer, and we also talked about the risk factors for cancer, can you enlighten the audience about, at least the listeners, about what exactly are the symptoms of cancer?
Now, unfortunately, again, we cannot put all cancer, a single symptom which we can tell will correspond to cancer. What we typically tell, loss of weight or loss of appetite, many times you may not see it in, say, cancer of the breast or this thing. And there may be many other conditions like tuberculosis, which can have loss of weight and loss of appetite. So though these are the regular this thing, it may not be very specific to cancer. Now, but where a person needs to be worried, I can tell those things. Now, any abnormal bleeding, either from while passing stools, or say a woman has attained menopause and then has bleeding, these would increase the suspicion of cancer. Again, I would not tell that these symptoms are 100% confirmatory of cancer, but the probability is much higher. If there is an ulcer which is growing in size or not going away with regular treatment, especially in the mouth or this thing, then we need to be worried about cancer. Then this one, an elderly patient, especially if he is complaining that he's having difficulty in swallowing, I would be worried. Any change of voice, again, the chance with age, though there are many causes for all this, but these things, change in voice, difficulty in swallowing, persistent cough with the blood in the sputum, all these can be symptoms of cancer. But the symptoms of cancer are highly variable. There is no one pattern that which we can tell. But if any person has these particular this thing, at least he should take medical advice and consult his general practitioner or this thing for evaluation for cancer.
Yeah, I think that was a very comprehensive answer from Dr. Kamath. And like Dr. Kamath mentioned, certain times it's very difficult to say that the patient will have these symptoms, the typical symptoms of loss of weight or loss of appetite. And certain times we keep seeing patients who are well preserved, absolutely no symptoms coming in, and the imaging showing stage 4 malignancy. These things are also getting commoner these days. But I think he summarized it very well. So I think now we can move on to how do you diagnose cancer?
Yes.
So this is a very important thing.
Yes.
So how do we diagnose cancer?
See, for first thing, whichever the symptoms that we have mentioned, I said we need to go to a doctor. Now, it should be preferably a doctor who is well versed or dealing with cancers. Now, he does a general examination, checks for any whether there's a physical examination. The thing which we use very commonly for cancer is biopsy. Biopsy means removing a small part of the tissue for examination under a microscope by a pathologist. Now, say a elderly lady, a 60-year-old lady goes to her general practitioner with lump in the breast. The test which would be advised is to take a small amount of tissue from the lump and send it to the pathologist for examination under the microscope. This is called a biopsy. The simplest form of a biopsy would be a needle biopsy or FNAC. Now, most of the time, the pathologist will be able to tell us whether there is cancer or not. But there may be gray areas. Sometimes the amount of tissue required might be more, or sometimes the tumor might be in an area which is not easily accessible for biopsy. So the next thing which you would use is imaging. Imaging is also various types. Earlier we used to talk about CT scan and MRI. Now we talk about PET scan. PET scan is a very useful investigation, not for the diagnosis of cancer, but for staging of cancer. Because once you have the diagnosis, the next step would be to see how much it has spread. And for this, the PET scan is very, very useful. And depending on the organ that we are looking at, we may have to ask for more tests. Like suppose a patient has got difficulty in swallowing, then the clinician would suspect that there is something in the food pipe or the stomach. In these cases, he would ask for an endoscopy to be done. Or in some cases, a patient comes with abnormal blood in the stools, which can't be explained with regular this thing. In these cases, a scope may have to be passed from below what is known as a colonoscopy or a sigmoidoscopy. And depending on the situation, we will have to do the test depending on which cancer we are suspecting and this thing.
So just to add to what Dr. Kamath mentioned, yes, biopsy tissue is an important thing. It's sometimes becomes an issue, and we have to get the tissue and see the pathologist has to see it under the microscope and come to a diagnosis. But certain times, like Dr. Kamath mentioned, it's a grey zone. So we have to resort to what is called as something called immunohistochemistry. This is based on something called antigen-antibody reaction, which the pathologists know it very well. And that way we are able to diagnose cancer with a greater accuracy. And even the subtype of cancers are diagnosed with lot of accuracy based on this immunohistochemistry. And this PET-CT has now become a single one-stop investigation for all the most of the malignancies. And it is metabolic imaging. So we are able to know the size of the tumor and also know how active the tumor is. This is also important. And one thing which maybe just to add to what Dr. Kamath mentioned, there is something called tumor markers.
Yeah. Yes.
For example, colon malignancy. Just to support the cancer's diagnosis, we can do something called the CEA level, plasma embryonic antigen level. And if it goes up, that again supports the diagnosis of a cancer. Even in ovarian cancers, we have CA 125. If it goes up, again, the chances of this patient harboring a cancer is higher. So that's about the diagnosis. And once we diagnose, we have to go to the staging aspect.
Maybe one thing, yes, staging of course is important for any cancer, because it's not just important to know where the cancer is, it is also important to know how much it has spread. For this, usually we rely on the radiological investigations like CT scan, MRI, or now PET scan. Now, one aspect I think which would be of a lot of interest to me, this one is that how do we prevent cancer? Is it possible that can I do something that I never get cancer? Is there something like that? This question I come across very frequently when people talk about cancer. Maybe you can shed some light on
Sure.
that.
So number one, like I told you previously, we've also mentioned about there are certain modifiable risk factors and non-modifiable risk factors. Modifiable are the ones which we can definitely modify. Number one, alcohol and tobacco. Two important risk factors for cancer, which contribute around 1/3 of all the cancers. If we are able to limit alcohol and totally stop tobacco, so tobacco cessation, it can go a long way in actually preventing various malignancies like cancers like oral cavity, lung, so on and so forth, pancreas, the list goes on and on. And then, of course, consuming a lot of green leafy vegetables, fruits, which is highly rich in antioxidants and vegetables, and also maybe reducing junk foods. So all these can go, and physical activity. There has been a lot of studies that physical activity every day, half an hour of aerobic exercise every day, does lead to lot of production of lot of free radicals and antioxidants, which can go a long way in preventing cancers. And of course, certain things like your genetic factors, it's difficult to control it. But if your cancer runs in the family, there is you will have to consult your genetic counselor, and based on that, there are certain genes which can run in the family. And then maybe Dr. Anil Kamath, after I finish, can throw some light on what is called as cancer cessation, risk-reducing surgeries for certain malignancies. And once you talk about that, then we can talk about screening.
Yes. So now prevention, again, there is no sure shot way, I would say. You can modify things, but again, there is no absolute guarantee that you will not have cancer. Now, regarding risk reduction, now depending on the what the risk is, we can try to reduce the chances of this thing. This is especially true, say, in breast cancer. This is where the risk reduction has reached maximum investigation, I would say, or we know most about risk reduction in this thing. This happens, some of these, what we used to think is non-modifiable, like genetic this thing. Now, suppose the mother has breast cancer, there is a small percentage of chance that this could be familial, and she might have a gene which is transmitting to her daughter or granddaughters or any this thing. Now that is possible. Now most breast cancers are not familial or not related to these genes, but there are methods now in which this gene can be tested. And this gene is the most commonly known gene is, in short, we call it as BRCA, BRCA. Now, we can test the daughter who doesn't have the disease at this point of time. We can check her this one to see if that particular, she carries that particular gene. And this would be much better than her panchanga or this thing to predict what her life would be, this thing. What is her chance in future that she will have breast cancer? In some cases, the chances might be as high as 90% or 100%. So we have gone to that extent of this thing. In those cases, sometimes we do recommend removal of the breast prophylactically before the cancer occurs. These are called risk reduction surgeries. And it was made famous when Angelina Jolie underwent such a surgery. So such type of surgeries do exist where you can do things beforehand. But of course, it requires a lot of genetic screening and testing for these genes.
Yeah. So now let's go on to screening. So screening is nothing but employing certain tests which could be in the form of imaging or a blood test, which can go a long way in diagnosing the cancer early so that the patient can live longer. So it's generally done for asymptomatic individuals, normal people who want to get tested and they want to know the risk of cancer, and in the process they get detected early, and that way you get something called lead time. You can diagnose it early, you can treat early, patient lives longer. So Dr. Kamath, can you throw some light on breast cancer screening?
Yes. Now the two common cancers which we told in females, one is breast and one is cervix. Now both these cancers are highly amenable to screening. That is, you can detect it at a very, very early stage. Now you can detect breast cancer which is the size of a pea inside the breast, and the test used for this is a mammogram, which is basically X-ray of the breast. Now you can imagine this size, it will not be felt by the hand. Even an experienced doctor, if he palpates the breast, will not be able to find a lump which is this small size. The mammogram can detect it with a fair degree of accuracy even when this is that small. And detecting the cancer at this small stage has many advantages. One, the treatment which is required will be very, very simple. Maybe she'll require only surgery, very little role for chemotherapy and other things in this early stage of disease. The outcomes, we expect nearly 99% chance of cure as compared to say a 50% or 60% in the higher stages. So mammogram has really helped us to detect cancer in a very, very early stage, much before it can be determined by any other test. And abroad, in more developed societies, there is recommendation for universal mammogram. Most ladies who have crossed the age of 40 or 50, they are supposed to have an annual mammogram. Unfortunately, in India, we don't have a national policy for doing these sort of tests. But we do get patients who request this thing, and we do selective screening depending on this one. Most of the time, along with the routine health check for females, we do a screening mammogram.
So, Dr. Kamath, it's more of a surgical domain. I would like to ask you, this may be of a lot of interest to our listeners. What do you think about this breast self-examination and breast examination by a healthcare professional, and when it should be employed?
Yes, so we do get many ladies who come with lumps in the breast, or they are worried about breast cancer. Now, not all lumps in the breast are cancer, especially a young lady, say in her 13, 14 or in her teens, comes with a very well-defined lump in the. It's very likely that this is a fibroadenoma, or what we told earlier, a benign tumor. Now, we have to advise these ladies something so that we don't miss out a cancer in future. And what we tell them is to do a self-examination. There is a way in which it is done, especially using 3 fingers. Like the clock, we start from one area and examine all the other areas. Now, we are not expecting the lady to diagnose a breast cancer by herself. We just tell her, if you find something abnormal, just know your body. And if you find something abnormal is there, once in a week at least, you can do it. And if you find something abnormal, please come to the doctor and ask him to check again, and if required, do a mammogram. So this is what is called self-examination. It is not an end to itself, but it is a means to an end, so that the lady can suspect something and come to the doctor for higher tests. So this is what we would recommend most ladies who are, say, below 40, above 40 or 50 to do a regular self-examination and annual mammogram.
So let me go on to the screening for colorectal malignancies. So we know that though colon malignancies and rectal malignancies were once considered the disease of the West, nowadays because of various factors including lifestyle and our eating habits, it is slowly increasing in incidence even in countries like India. So any man or woman over the age of 50 years should undergo a colonoscopy at least once, and then subsequently once in 10 years. And there are also other methods of detecting it, like you can look for any hidden blood in the stools, which is called as occult blood testing, simple stool testing. This can also go a long way in detecting colon malignancies early, and we know that colon malignancies detected early have got excellent survival. So that's about colon. Any thoughts about prostate malignancy?
Prostate cancer was basically a disease of the West. It was one of the most common malignancies, especially in USA and in this thing. Now, prostate cancer is amenable to screening. That is, you can detect it with the test. And the test which we use here is a blood test. And it is called PSA, or prostate-specific antigen. This blood test, especially if it is done in elderly people, will help us give a suspicion. If it is very high, again, it's not a diagnostic test, but it will help us raise the suspicion, especially if the PSA is high. It would make us look for prostate cancer in a better manner. At the same time, I would like to add that not all cancers are amenable to screening. Some cancers, the tests required are either too tedious or too difficult, or they just don't pick up in an early stage. Only certain types of cancers are amenable to screening, and most common are these: breast and cervix. And in males,
since cervical cancer is very common in India, I think we should also tell our listeners about how we screen for cervical cancer.
Yes.
So
cervical cancer is screened usually by the gynecologist. They take a scraping from below. They insert a wooden spatula. Just take few scrapings of the cervix, put it on a glass slide for the pathologist to examine. And these scrapings, you can, if you see abnormal looking cells, you know that either there is a cancer or there is changes which over time can go on to become cancer. This is called a pap smear. Pap smear is again a very useful test for early detection of cervical cancer and also precancerous lesions, things which have not yet become cancer but have the potential to go on to become cancer. And this is also advised once in a year. So depending on this thing, and if it is normal, you can increase the frequency to once in 2 years. So these are the two tests, mammogram and pap smear. If I have to give a message to especially elderly ladies, please go and get these two tests done if you all have not done it, because they do help in detecting cancer very early.
Just to add to what Dr. Kamath mentioned, nowadays there is a lot of data which is coming up with regards to cervical cancer vaccination.
Yes.
So we are trying to prevent what is called as CIN 1, 2 and 3, which is a pre-malignant condition which can go on to become a cervical cancer. So women in the age group of between 9 and 26, girls from the age of 9 years till 26 years of age, it's recommended that they go for vaccination against cervical cancer. In this regard, because we are talking about vaccination, there are also vaccinations against hepatitis B, which is a virus which can cause liver cancer. It can go a long way in preventing cancers. And nowadays we are having a lot of people coming in, they're asking, chronic smokers, they're coming and asking us, doctor, is there any screening test for lung cancer? There is some data which is coming up these days. Men or women in the age group of 55 to 74 who have been chronic smokers for the last 30 years, smoking significantly with what we call as pack years. They're smoking more than 1 pack per day for the last 30 years. There is an increased incidence of lung cancer. There is what is called as low dose CT scan, where the exposure to radiation is also less, and low dose CT scan can be used in this situation to diagnose lung cancers early. So that's about screening. Now, since we have done all the investigations to diagnose cancer, and we've also told about how we can prevent cancers, I think now we should go one step further. In case the patient is diagnosed with cancer, what is the next possible, what is the treatment?
Yes. So now any cancer diagnosis, I'm sure will come as a shock, not just to the patient but also the family. Now the crucial decision is where should they take treatment. Now we have reached a stage where earlier there used to be just one treatment and the doctor used to say you take this treatment, either the patient used to get cured or he used to die because of the disease. Now things are not like that. Now the present day cancer treatment is all about options. Now first of all, where should the patient take cancer treatment? Now there are what are known as comprehensive cancer centers. There are basically three modalities of treatment: surgery, chemotherapy or injections, and radiation, which are basically rays. Any place where all these centers are present together under one roof would be called a comprehensive cancer center. And it is a well-known fact that those who take treatment in comprehensive cancer centers do much better than, say, when a patient is treated individually in a nursing home or in a hospital where all these facilities are not available together, because the coordination between the different specialties is much, much better as compared to this one having things separately or doing it separately. And like I said before, cancer treatment is now all about giving options. Just an example, earlier any lady with the cancer of the breast, the doctor used to say you get the breast removed, and that was the only option which was given to her. But now the options are not. We have got equivalent results. We need not remove the full breast. We can just remove the lump with the margin, preserve the breast, and then go for radiation. So we can give, this is option A, this is option B, depending on what you want, depending on your financial resources. We can either choose A or B. So it is like giving options to the patient with the same outcome. It's not like if you choose option B, your outcome will be poorer. But we are now giving options, especially less radical options. I can talk about surgery because I am a surgeon, so I can tell earlier the principle used to be as radical as possible. Remove as much as possible. Don't bother about the disfigurement. Don't bother about the problems. Ultimately, life is more important than any of these, but it is no longer like that. We try to maintain the normal shape and this one as compared to this thing. So nowadays it is about doing less radical surgery, preserving as much as possible, and appropriately adding chemotherapy and radiation. So this is how surgery has changed. So maybe Dr. Vishwanath can tell about how chemotherapy has
changed. So to add to what Dr. Kamath said, things have evolved significantly. What you said was organ preservation. We are trying to preserve the organs, which is not only for breast, for various other cancers like even rectal cancer. We are trying to do what is called as organ preservation and head and neck malignancies, larynx. And before I go on with chemotherapy, I had a couple of questions if I can ask. I think now things are slowly reaching a point where we are going into what is called as less invasive surgeries. So we are going into what is called as minimally invasive and robotic surgeries. Maybe patients are maybe interested. I mean, people may be interested in knowing this.
Yes, one is about preserving the organ. Another is doing the same surgery, like removal of the through a smaller incision. So this is where minimal invasive surgery comes in. So especially for abdomen surgeries or chest surgeries, normally we used to put a big incision so that we get good exposure, we can remove the tumor widely. Now we can do the same thing. Because of the advancement in this one, we can just do the same thing with the small holes in the abdomen using long instruments and do the same clearance without compromising of the patient and give the same results. And though the surgery done inside is the same, the patients recover much faster. The pain they have to suffer would be much lesser, and their return to activity would be much faster. I must add that in most of the cases, the outcome is the same as open surgery, but especially in terms of pain and in terms of return to normal activity, minimally invasive surgery through both this laparoscopic and robotic scores over open surgery. But open surgery has its place when it's not suitable. Not all cases are suitable for this minimally invasive surgery. But there is no harm in discussing with your treating doctor regarding these choices.
Yeah. So since Dr. Kamath has told everything about surgery, now my domain is medical oncology. So medical oncology is a newer branch, and since 1970s we have seen a significant change in this paradigm shift in this branch. Initially, it was more of this chemotherapy, and there's a lot of myth associated with chemotherapy that chemotherapy kills the DNAs, and there's a lot of side effects, and it causes only unwanted effects rather than wanted effects. But these are all myths. We have gone a long way, and the way the chemotherapy is delivered has become different, and the patient's side effects have also lessened with the improved quality of chemotherapeutic agents, and we have become more specific, what we call as targeted therapies. Targeted therapies, it's nothing like it's just like a magic bullet. We want to cause only the damage to the tumor tissue and less damage to the normal tissues. So that is one of the reasons it's called as targeted therapy, and it goes and specifically binds to that particular mutation, attacks that particular mutation, so the unwanted side effects are much less. And not only that, now we have come to an era what is called as immunotherapy. Immunotherapy is the treatment what we give. It goes and modulates the body's immune system to kill cancer cells. It's as good as your own immune system is killing cancer cells. That is the newest discovery as far as medical oncology is concerned, and in the last 3 or 4 years we have seen that several malignancies do very well with these immunotherapies, and we also have had the experience of treating several patients with these immunotherapeutic drugs and targeted therapies at our Apollo Cancer Center.
Well, one thing that we didn't touch upon, because we didn't have a radiation oncologist, radiation too has advanced quite a bit from the earlier cobalt machines, which used to cause a lot of peripheral damage. It was like bombarding a big area. That has also grown precise with the modern day equipment, what we call IGRT and IMRT, the planning and the precision. The area which you want to deliver, the rays are delivered only to that area with the minimum damage to surrounding areas. So radiation also is an important modality for cancer treatment, has undergone a lot of advantages a lot of advances in terms of precision and better delivery.
Since Dr. Kamath spoke about precision oncology, so like he said, precision oncology is more about causing maximum damage only to the tumor tissue and preventing all unwanted side effects. And these days, even in medical oncology, we have what is called as personalized medicine. So probably 20 to 30 years back, it was more of a blanket therapy. Every patient, lung cancer, you give the same kind of treatment. But now we have significantly evolved, and what we do is next generation sequencing. We analyze the entire genomic landscape of the tumor cells, tumor tissue, and we know that patient X has got a particular mutation and he gets a type of treatment, a targeted therapy, which may be different from patient B who may not harbor that particular genetic defect. So that is why this personalized medicine is very important, and that's all about tailoring the treatment of the patient based upon the tissue biomarker or the gene which is present with the abnormal gene which is present in a particular patient. This is called personalized medicine, and almost every other patient these days are getting personalized medicine, personalized oncology care these days.
Yeah, and finally, what is important for any cancer is not just surgery, chemotherapy, and radiation. We need to look at the psychological aspect also, because cancer patient's mind will be going through a lot of turmoil. He'll be worried whether he's going to survive for the next this, and there may be various things in his mind. Psychological aspects, that's what differentiates a good cancer, an excellent cancer center from other centers. Then you have rehabilitation. All our treatment leads to a lot of damage. So the patient might have survived, but the long-term damage is because of this treatment. Like radiation causes so much dryness of the mouth, or surgery causes so much disfigurement of the mouth. To get the patient back to his normal speech and normal swallowing and all, that requires a lot of rehabilitation. And finally, how you take care of your advanced malignancies. There may be certain cancers where nothing can be done. That doesn't mean that we just allow the patient to suffer and die. We should take care of these patients also. So this is where pain control comes in and palliative care comes in. We have to take care of patients who don't have any specific treatment, who don't have curative treatment, And a good cancer center should be able to take care of both pain and palliation of symptoms. So all this comes under a comprehensive cancer centers. So these are additional treatments which really help the patient apart from the core treatment, that is surgery, chemotherapy and radiation.
I think one thing which we did not touch upon so far is for every patient who comes into Apollo Cancer Center goes through what is called a multidisciplinary tumor board. So whenever a patient comes in, say a patient comes in to Dr. Anil Kamath, he diagnoses this patient with the CA breast, and then it's not like he just goes and operates on the patient. He puts it into what is called as a tumor board, where we have a dedicated medical oncologist, a surgical oncologist, radiation oncologist, pathologists, and radiologists who have done the imaging, and all of us sit together and come to a conclusion as to what is the best possible treatment for this patient, whether it's surgery and then followed by whether it's going to be breast conservative surgery or removal of the entire breast and followed by radiation plus minus, and then what kind of chemotherapy. So this is decided by, it's a concerted effort, and it's not decided by one particular individual or doctor. Do you have to add anything, Dr. Kamath, on this?
Yes, so usually these are the advantages of a comprehensive cancer center, because when the patient goes to a surgeon, very often what treatment is available in that center or what that gets recommended. Most of the time the intentions might be good, but it may not be in the best interest of the patient. Once it is discussed in the tumor board where all the doctors put in, there are automatic checks and balances. So the patient is more likely to receive the treatment which is in his interest rather than the interest of the doctor or the hospital.
Sure. So I think with all this we have reached a point where the survival has significantly improved in most malignancies, and there are certain curable malignancies also. For example, we have a blood cancer which is called as lymphoma. We are having long-term survivals. So we have definitely reached a point where patients are living longer, and we are definitely adding years to cancer patients.
Yeah, that definitely is the case. I'm sure we'll reach a stage where cancer can be cured in most of the cases, and even when it can't be cured, it can be controlled. Like diabetes, something which can't be cured but which can be controlled. So I'm sure we'll reach that stage. So with this optimistic note, I think we can end this one. Thank you, everybody.
Thank you so much for this one.